Welcome, everybody. We are so glad you're here for today's Dementia Friends and Associates special meeting. We invited today folks who have graduated from the Dementia Beyond Drugs, Changing the Culture of Care training that we've done here in Atlanta as part of our grant, as well as anybody else who wants to come and learn and just join us as we have a conversation about person-centered dementia care practices. So we're just going to jump right in. I've got a little PowerPoint that I want to show us because I want us all to kind of get on the same page as we're starting. As we're starting, I do want to ask if you all would type in who you are and where you're from, please. That will be awesome. And let me see here. Can y'all see the slides?
Yes.
Okay, perfect. Type in who you are and where you're from so that we have a good understanding. I didn't recognize some of the names, and I want to make sure we welcome everybody. So we always like to start with framing and reminding everybody about the Culture Change Network of Georgia and our mission. It's to change the way that we think and feel about aging and disability by creating the kind of care and support we want for our loved ones and ourselves. And acknowledging our two grants, our two CMP grants from CMS and the survey agency here in Georgia, and also our wonderful partners, Georgia Healthcare Association, Leading Age Georgia, Alliant Health Solutions, Georgia Medical Directors Association, and the Eden Alternative, and all of our other wonderful organizations and folks who are involved in the Culture Change Network of Georgia. So, Dr. Al Power, who we're going to talk about a lot, this is a quote from him, and he's really an expert in reducing antipsychotics for people living with dementia. And he said that dementia is the greatest shame of modern medicine, not because there have been no significant advances in treatment, but because from restraints to locked units, to the use of inappropriate antipsychotics, to electroconvulsive therapy, we have lost our recognition of the humanity of those who are living with dementia. And there are few signs that we are making much headway. He said that a while ago, and I think it's just a really telling quote to help us frame everything today. And we know that so much of what we're doing with dementia care just isn't working, and that we're looking at people living with dementia and focusing just on what's wrong with them and not what they can do. And we're just looking at the negative, and that really is creating stigma and excess disability for people. And we also all know that there is a tremendous misuse of antipsychotics and psychotropic medicines, not just here in our country, but all around the world. And in order to do something about it, we have to really change how we think and feel about dementia and behaviors. And if all we're doing is looking at dementia as a medical problem, then we're only going to look for medical solutions. And if we take somebody off a pill, but we're not looking at and addressing the reason why we put them on the pill in the first place, is that going to be all that they need? And we know the answer to that is no. So we at Culture Change Network of Georgia, with Georgia State Gerontology Institute, and you'll hear from Jennifer Kraft Morgan later, we really believe in this Dementia Beyond Drugs changing the culture of care curriculum. And we made it a part of our grant so that we could offer scholarships to Georgia nursing home folks and stakeholders in Georgia. And this curriculum was co-developed with Dr. Al Power and the Eden Alternative. And it's an experience class that really helps us reframe problem behaviors. It's not just looking at drugs, it's helping us relook at dementia and relook and reframe problem behaviors in quotes so that we can decrease reliance on antipsychotics and psychotropics and actually prevent the use and misuse of them when we can, and really know why. And it really helps us frame how and understand how our current approach to dementia care just isn't working. And it's a wonderful, we just finished the class this year, and it's a 7-week class, and it met twice. We had a lot of folks want to participate, so we had a morning class and an afternoon class. And it really gets into the experiential approach to dementia care. And it's based on Dr. Al Power's book, Dementia Beyond Drugs. And for those of you who just took the class, the books are put in the mail today, so you should be getting your books soon. And we've already talked about what the aims were, what we were trying to get at in this class. And one of the main things, Al's kind of definition of the experiential approach to dementia care is dementia is a shift in the way a person experiences the world around her or him, around them. And a lot of this gets at well-being. And well-being, this is a quote from Dr. Bill Thomas, who's the co-founder of the Eden Alternative. Well-being is a much larger idea than either quality of life or customer satisfaction. It's based on a holistic understanding of human needs and capacities. Well-being is elusive and highly subjective and the most valuable of all human possessions. But that word is so often used, but we don't really know what it means. It's kind of, we know in general. So years back, the Eden Alternative and a group of experts in culture change came up with the Eden Alternative domains of well-being. And that's what this chart is here. And it helps us really have a framework to look at and really deeply understand well-being, and also helps us get at addressing loneliness, helplessness, and boredom. So we focus on that a lot in this class and really get at helping people have identity and connectedness, security, autonomy, meaning, growth, and joy. So one other way to look at this is to understand the indicators of ill-being. And this is something that we know, but we haven't looked at it exactly this way. And this is from a group in the UK, and I think it's so helpful. When people are not experiencing well-being and they're experiencing ill-being, they have depression or despair, anger or aggression, grief, anxiety, fear, boredom, physical discomfort and pain, tension, agitation, and restlessness, apathy, withdrawal, distress, feeling like an outsider, and feeling and being easily walked over by others. Whereas when people are experiencing well-being, they're making their wishes known, they're initiating social contact, they are having warmth and affection, they have self-respect, they're helpful, they're having and experiencing humor, and their bodies are relaxed. They have creative self-expression. They're showing pleasure and enjoyment, smiling. They're responding well and appropriately to other people, and expressing appropriate emotions. And they're alert and responsive and active, and they're being purposeful. So I think this is a helpful way to look at the difference between well-being and ill-being, especially when we're talking about people living with dementia. And this is, as I said, from the Bradford Dementia Group at University of Bradfordshire in England. So what we know is there's no medicine that strengthens well-being. Another thing that's really cool and exciting is to know that the Centers for Medicare and Medicaid Services really has placed a significant importance on well-being and quality of life and preferences and person-centered dementia care in the state operations manual and in the regs. They even list the domains of well-being by the Eden alternative in the state operating manual. And this is really great. You know, we know that the regs don't just focus on quality of care, they focus on quality of life. And this is important. Quality of life is mentioned 101 times. Preferences, 217 times. Person-centered care, 46 times. Person-centered, 86 times. Alzheimer's is mentioned 11 times, while dementia is mentioned 122 times, which makes me really happy because it's dementia, not just Alzheimer's disease. And well-being is mentioned 135 times. So I think that is pretty remarkable. Now, when we're trying to talk about changing how we do things, we know that there's resistance to change, and people are resistant, and they have anxiety, and they have fear. And the fear is what is this going to be like, and can I handle it? And today we're going to talk about that and some ways to help everybody handle these changes and different approaches to get us there. Because we all want to help improve the lives of the people who are living with dementia and everybody who cares about them, including all of you and the providers and the families. So we want everybody to have a good quality of life. So I'm looking here, and I want to just, from a show of hands, if y'all are on the screen, who all in this group today has taken Dementia Beyond Drugs? I don't have everybody's hand. I know that there are some people probably on the phone who have not. So if you have not, just type in who you are if you haven't, and let us know who you are. That'll help us frame things. Okay, so today we're going to have some guest speakers, and I think first I'd love to have Danyce join us and just give us some QAPI, quality assurance information, and how we can think about maybe integrating that into what we're doing. And just introduce yourself and tell everybody who you are.
All right, so I don't have a fancy schmancy PowerPoint,
That's okay.
but I have other show and tells. So I am a quality improvement specialist from Alliant, which is the quality improvement organization that partners with Georgia. And for anybody that's not really familiar with the quality improvement organization, no worries. I was not either. I'm a nurse. I've worked in the hospital and long-term care. Um, I'm one of those nurses, I'm ashamed to say, that when I worked in ICU, I did not understand dementia. Then when I moved to long-term care, I was like, right? So
Right.
now I'm in quality improvement and I've been here for a year and a half. And I wish I knew then what I now know now and what's available. So on your screen, I'm sharing the homepage to Alliant, and I'm going to put that, if I can find it again, in chat. Otherwise, I'm going to put all the links in chat after.
Okay.
So the Quality Improvement Organization, very simply, is a group of passionate healthcare professionals like myself. So I worked partially through COVID. And then I had an anaphylactic reaction to PPE because we all know we were using what we needed, right?
Wow.
So anybody that's in the facilities, or bad word, in the nursing centers,
Good
um,
catch. Good catch.
anybody that's in a nursing center, been there. I haven't been out for long. So I know what's going on. So at the Quality Improvement Organization, it's made up of a group of healthcare professionals. It's administrators, nurses, pharmacists, nutritionists that are passionate, and all they want to do is help. So we are designated or tasked by CMS to simply partner with any healthcare facility providers and try to help you address some of the difficult topics that are tough to handle, like readmissions, falls, immunizations, infection control, chronic diseases. And as we know, dementia can lead to falls, readmissions, and many things. Um, and dementia or some level of cognitive impairment is common, as well as, a number of things. So Alliant wanted to put together a sample QAPI template
And
to
what does sloppy mean?
okay, so QAPI is Quality Assurance Performance Improvement. And in the State Operations Manual, it states, and I'm going to share this with everybody, in the State Operations Manual, nursing facilities should be really focused on their quality assurance and performance improvement plans and programs. So this can be something that if you're trying to figure out where to start with this, we've kind of laid it out for you. CMS has what's called QAPI at a glance, Quality Assurance Performance Improvement at a glance. I'm going to share that link with you. It's a little catalog of, I think, 32 pages that literally talks you through what is quality assurance. This blank form is in that group of papers. So I'm going to share the link to Alliant. I'm going to share this blank form. I'm going to share QAPI at a glance with you. We put together a template form for how to get a program up and running. And to make it a little bit easier and free, because that is a good F word,
Yeah.
correct?
Free is a
Okay.
great F word.
Okay.
Yeah.
So because we all like the free word, we thought we would start simply by using the CMS hand-in-hand program. And anyone that was in these classes saw a few of those videos and how effective the care a partner was in helping the elder brush her teeth, and some of the other examples in the hand-in-hand videos. I'm going to
Right.
share that link with you. It's all free, a whole set of modules. So for people in those nursing centers, you can, it can be assigned for off shifts, weekends. You know, it's not one of those things that's dependent on someone being there, providing it live. This template talks you through what you want to accomplish, providing person-centered, empathetic care to our elders, using the CMS hand-in-hand training series. Who's
And
going to be involved? Yes.
Danyce, I'm going to bounce out and say, this is walking us through how to do SMART goals, right?
Correct.
And she's going to walk you through what that is and what
Yes.
each of the letters mean, SMART. And just so you all know, this is an example that you can use and come up with your own way to do it. But this is a great example and a starting point. We also have a SMART goal video to help people understand what SMART goals are. So, okay, didn't mean to interrupt.
No, interrupt as much as possible, and anyone interrupt. I have 4 kids. Please interrupt. I'm going to just keep going. So SMART goals are specific, correct, measurable, attainable. We want to be able to be successful. Are realistic and time bound. You don't want it to go on forever.
Right.
You want a time frame that's realistic, and then you're going to go back and check it out. And that's all in this CMS at a glance booklet.
And
It's
I
going to
want to add too, right, that this it's not just nursing homes that can use these approaches and
correct.
tools. Any organization who is wanting to make improvements in their dementia care practices can use these tools to help them frame how to do it. Correct?
Absolutely. And that's what's great about performance improvement and SMART goals. And I refer to the CMS as a guide because it just breaks down who should be involved in the process. You should have the direct caregivers. You should have some kind of a plan. I won't go through all that right now. However, that's what we're here for from Alliant. And I'm going to put in one of my friends, colleagues, and favorite people, Melody Brown. I'll stick her email for you to also. She is the state quality representative for Georgia. So I'll stick.
Most of us, a lot of us know her well. So
Perfect.
yeah.
And so if you're interested, she can help you build whatever you want. So who will be involved? And that's where, again, this is a template. And I purposely put it on a Microsoft Word document so you can delete, add, whatever. Under the who section, we put in staff and family care partners, because as we talked about in the program, anyone that has an interaction, including the family and the friends, how often do we see that the family comes in, Mom, did you have your shower today? Mom, what'd you have for lunch? Next thing you know, it all falls apart.
Right.
So the family should be involved, right?
Because
I did not
know, they don't know what they don't
know.
But also they know a lot that can help.
Right. And that's where preferences can come in. I've got so many stories of when we finally got preferences from family, how everything changed. I did not put in who would be providing or facilitating the program, because that's really Up to you guys. Would it be every department's manager? Because that's the other thing. Every department needs to be involved. One of the best examples I always give people is, say you're sitting at home and you're in your lounge chair and you're relaxing and watching TV and drinking a glass of water, because that's what we all drink when we're at home sitting in our lounge chair watching TV, correct? Right.
Well, we drink some other things from time to time, but
Well, I'm trying to be, you know, it is between the work hours. So,
yes, yes, yes.
so we're all sitting at home and somebody comes in our house and they start moving our stuff around and then they leave with a bag. Now, you're going to call your friends and you're going to be upset and you're going to be anxious and you're going to, everyone's going to feel that's valid. Now let's make you in your 80s in your nursing home and the same thing happens, but you have dementia. So you don't remember it happened, yet your stomach is churning, right? Because you're still upset. So then the next person comes in, Mary, let's take a shower. No, I don't want to. Go away.
Yeah.
So Mary, the CNA, goes, she's having behaviors.
Behaviors,
Right?
behaviorals.
Correct.
And we say behavioral expressions, but she's having behaviors. Yeah.
She won't take her shower. She refused. Well, if you backed up a little bit and actually watched, it was actually housekeeping that went in the room, cleaned her room, and emptied her garbage. But nobody actually told her that. So you need to make sure every department is aware of how to interact. Very simply, I'm here to clean your room. Then before they leave, I have your garbage. Have a nice day.
Yeah.
They're not going to remember, but what else is not there? That churning.
Yeah.
Right? So who is involved is going to vary. Have every department shift supervisors, weekend staff, as long as everyone is covered. Where will it take place? Well, it's online and it's free. So
Right.
wherever.
And it could be that a particular organization would want to, have it at the organization during a specific time, and they could address that and how they filled this out.
Exactly.
Yeah.
One thing about this is you do need to edit it to make it yours.
Right.
Just like we make care plans resident specific or person centered, your performance improvement plan needs to be specific to your needs.
Right.
So
Exactly.
each of these things we put in, okay, what measures? Well, it's tough for me to put in numbers. I don't know how many staff you have. I don't know how many, elders you have. I don't know who you exactly want to address, but we're going to use the percent of staff, percent of elders. You need to get a baseline. Then, what's your current data? Okay, well, how many of your staff have already had training? Is it 0? That's okay.
Yeah.
It's just going to, when everybody's done, you're just going to feel more successful. So what do you want to increase or decrease that number to? Well, again, let's be reasonable. Do you want 100% of staff? We use a lot of agency staff. So is it more realistic to say 95% of staff? Because I want to give myself that 5% wiggle room for my agency staff. Or do I want to say 100% of my staff?
Okay.
And 85% of the elders will have at least one of their family. Again, in the training, their family does not have to be biologic. It
Right.
can be whoever knows them. Attainable is whatever you have set, is that reasonable? So did you base the measure or figure that you want to try to get at best practice, a benchmark? So we put in some information here just to guide what you should try and figure out your measurements with. Is the goal measure set too low, that it's not challenging because you want to challenge yourself?
Yeah.
Does the goal measure require a stretch without being unreasonable? Again, you want to challenge yourself. You don't want to be unreasonable, but yet you do want a bit of a stretch. Relevant in the SMART goals that are. So how is the goal going to address your business problem? Well, the CMS hand-in-hand training was created specifically for nursing homes with a comprehensive training that emphasizes person-centered care. So right here, I'm saying that this training is going to address my problem of not enough people understand dementia, and my elders are not having lifestyle of well-being.
Right.
So
Exactly.
time bound. Now, do not get frightened by these dates. We put in dates, the target date for achieving a goal. Again, edit. But try to give yourself a time frame to say, I'm going to try to get this done. I really want to get this done by, the first quarter next year. I want to get 50% done by the end of this year, at least on our dementia unit. What's best for the residents? And then some goal statement examples. So we put in some other examples just to share with you and help you try to guide, some of your individualing of the plan. Does anyone have any questions?
I'm looking to see if anybody has any questions. I'm not seeing anything.
I'm
Jen,
seeing that
you're-
Mel is the best.
Can I ask a question?
Yeah.
Maybe warm people up. How all nursing centers are required to do QAPI plans. How
Mhm.
many, in your experience, have ones that are related to culture change or person-centered care or well-being sort of metrics? And anybody who's on the call who has experience with those sorts of QAPI plans is
perfect.
welcome to speak up.
Yeah. Unmute, pop on, and tell us.
Hey, it's Jennifer from Ridgecrest. How are y'all?
Hey, Jennifer.
And Jane and Karen
Hey there.
and Adele.
Here.
So we have not included that yet. My question is, how do you quantify it? What data are you recording or documenting? How do we accomplish that in a meaningful way and be able, what data are we capturing? That's my question.
Quality of
It's so great
life
to see y'all, by the way. So great to see y'all.
of life goals are difficult to quantify. So, that's as far as I know, that's a difficult question to answer unless you're going by a number of psychotropic medications and the number of behaviors and expressions seen and documented, and see how much you can reduce either one of those values, because those are measurable. They're goals of care. They definitely impact quality of life. the number of falls, you know, you can take things like that that impact their eating, weight.
Yep.
You know, I mean, I'm just trying to free think, what are values and quality of life? For me, it's food.
So we do track very specifically our psychotropic medications, all those antidepressants, sleep meds, all of that. We track it every month. Our consultant pharmacy does that, and they give our numbers, they give our percentages compared to our state and national numbers. So we do track that very closely. So we've got a lot of information that we use in our QAPI plans. We do have a plan for falls. We have a plan for weight loss, wounds. What else? We got a lot. Not to mention the stuff that we have included in QAPI for like plans of correction type things. We've got several of those from over the years that we still, the ones that we find value in continuing to track.
One of the things that I think we're really trying to point out and help all of us understand, a lot of people, when we start talking about things about culture change and person-centered care, and, once people take a class like Certified Eating Associate Training or Dementia Beyond Drugs, they kind of get freaked out like, oh my God, this is a whole new thing. It's a whole separate thing, as opposed to thinking about how to integrate it into what you're already doing with your QAPI plans and in your quality improvement plans. And the example that Danyce gave us there was counting what percentage of people have gone through some education.
Exactly, Kim. I think the point there is that it's process metrics. So when you're starting, a way of doing that is doing process metrics, which is saying how many people have I trained, how many times we've mentioned this in huddles, sort of things that are much easier to count to start on your journey. And then if you're doing some reflection about how it went, you'll have a better sense from your team about what outcomes you think that you could actually move. Maybe it is that people have seen people doing better in terms of eating. Miss Smith was doing better in terms of eating, but Mr. Kemp was not, was having less behavioral expressions, or was doing better in terms of having somebody helping him brush his teeth. So, I mean, it's not going to be straightforward always as to what outcomes you can tie it to, but you can always start with the process metrics like Danyce said.
I think that's important too when we're thinking about dementia education. When we're thinking about dementia education, the more people that get and learn and understand dementia and how to do person-centered dementia practices, going to end up affecting the other things. If people have learned how to have good relationships with people with dementia and communicate properly and approach them in the right ways, over time, that's going to improve eating and falls, and it can improve a lot of things, so anyway, just kind of throwing that out there. Any other thoughts, Danyce and Jen, about that? I like this idea of starting with measuring. What did you call it, Jen? You used a scientific academic word.
I mean, they're process metrics, right? They're counting things. They're counting things that you're doing, and those things that you're doing matter, right? So, you're having these meetings about it. The Quality Improvement Committee is meeting about it and talking about it. You're using it at huddles. You're providing the education to X number of people. Like that's not the end goal, but it is a way of getting towards where you want to be. So then you can set another goal when you've gotten through this. I'm sorry, Jennifer, did I cut you off?
No, ma'am. I'm not sure which word she was talking about, but we're quantifying what we're monitoring and the data that we're getting. We're trying to be very specific, particularly on psychotropic drugs and antidepressants and all those.
Right.
And we do track reductions, trial reductions. We do that with everybody. And it's routinely, it's kind of on a schedule. So, and then we document if it didn't work or if they're doing okay in the reduction. So we really do try to use just the minimum of what is needed, because there is no quality of life if you're over medicated.
Right.
And no quality of life if a medication is debilitating you over time and you're losing all your functioning because of the medication. So we watch that very closely.
Awesome. Leanne, I see your hand. Yeah.
There you go. I'm so sorry. I just had a question about, like, I work in independent living. And so I had a question about skilled nursing. The psychotropic drugs, aren't they would be prescribed by a physician. So how in it kind of, how do you, because they're not here in this, they're not in this class. How do you get buy-in from the physician who's prescribing these drugs?
Oh, you are just asking the perfect question. So Dr. LeAnthony Hardy was supposed to be with us today. He is a certified medical director and works with multiple nursing centers. And he couldn't come today. He just took the class with us, and he wasn't able to come because the state came in and they're being surveyed right now. So unfortunately, he can't join us. But we do have as a guest speaker, and I'm going to go ahead and jump to this, Danyce, and we can kind of go back and forth. But we have Mr. Perry Kemp, who is the executive director of the Georgia Medical Directors Association. So Perry, and he's also worked with the QIO and all kinds of things. So, and you're a pharmacist. So talk to us about this and just what do we need to know about how to get the right people involved and at the table, Perry?
Okay, so first, speaking as a pharmacist, I'm highly offended that you're wanting to take all these drugs away from these patients. How do you expect me to feed my family?
Yes. Well, yes, but we're not talking about all the drugs. We're talking about.
I can sell aspirin all day.
I know.
Okay, seriously, that was an issue when consultant pharmacy became live in the late 70s and early 80s. They said that's a conflict of interest. Why would a consultant pharmacist come into a building and make recommendations that would cut prescriptions? And it took us probably about a decade and a half to convince everybody that we don't count prescriptions. There's plenty of drugs to go around, plenty of things happening, and never did a consultant pharmacist get grief from a pharmacy manager that they could see their business going down. So we finally put that to bed. The second thing that had to happen was we had to get the doctors on board. I can't tell you the number of times that I had a doctor write a note back to me that says, "What, do you think you're a doctor? I'm the one that's the doctor. Don't question what I do." Generally, we go along with that until the doctor orders a fatal something and we stop it and we save his bacon, and then they become friends. When we put on medical director meetings, I had one doctor that sit in the front, and it didn't matter what the subject was. His first question was, "Well, how did I get the damn pharmacist off my back?" So we've had a lot of good times. So we've come a long ways. I was just sitting here thinking about the things that I've been in, the numbers of hours I've spent sitting in a nursing station and observing people. Oh gosh, I bet I've been in hundreds of QAPI meetings in different buildings, and we learned to do that through Joint Commission and through the state, and it was difficult. And we started out simple. We counted things. We were told by the surveyors as they kind of built up, you've got to look for your antibiotics, your infection control, your falls, your wounds. And so that pretty much set our agenda for the QAPI meeting. But we didn't spend a whole lot of time on activities and social services. I can't remember ever someone saying, well, just our general well-being of our patients. Do our patients look happy? Where are our patients? Are they sitting in front of the nursing station with their heads bowed and no responses? What's going on in activities? Do they actually show up? Do you have to drag them to activities? What can we do to help that? I never saw it happen in all the QAPIs I've been in.
And
So
Perry,
that's why I'm so excited about this kind of program. I took the eating alternative and then immediately went into Dementia Beyond Drugs. And Kim and I and Jen, we did a thing for our physicians. And I was really surprised at the physician uptake and then how they took that course. LeAnthony was there. I had a group of ethical physicians, Ringer and Warnock, and some of my, gang. And what was really funny is when Kim had them write down all the things that were important to them that they enjoyed doing, and then they switched the papers and marked off some of those things and handed the papers back. And I thought I was going to have a fight on that table. You took away my so-and-so. And for 3 days, that's all I heard during that meeting. So, it was all done in fun, but they took it. They understood it. It really shocked them, I think.
and that's for y'all, that's the simple pleasures exercise.
Exactly.
That most of y'all have done if you've gone through any of this stuff.
Yeah.
Yeah.
And they had not done that before. I'm sitting here thinking about staff stability. Where do you get stability when you're trying to put a program into something like this? You got to have the buy-in all the way to the physician. And I'll tell you, not many physicians like prescribing antipsychotics.
Right.
They don't like these drugs. But how do they get prescribed? It's when the staff or the families just bug them to death. I can't stand my mama doing this, so give her a drug.
And Perry,
we can't get our job done. If we could get her to calm down, we could have time with the other patients. So
I'm sorry, that's so it's because our society is so
exactly.
used to fixing things with medicine. And people have to kind of unlearn that approach, right?
Exactly. And it comes from both ends. If I know it may be 2:00 in the morning and you just got that phone call, can you stop a moment and do a little bit of teaching? Does a doctor realize that the chances are that phone call at night is on the swing shift because that was the new hire? And then that goes back to what did we teach that new hire before we threw her on the swing shift and had a warm body there? So that's a QAPI issue that, needs to be counted. How do we orient people? But it falls down to what Kim's mission is. If she's looking for that critical mass, if she could get lots and lots of people that understand this in their head when they quit their job and go to another job in long-term care. They've already got it in their head. So you're getting to the point where the nursing home has a critical mass. Of course, there's going to be turnover, but when that new employee comes in and they look around and go, oh my gosh, this is the way everybody acts, I better act that way. And or they'll come in there and they see bitching and moaning and, you know, people slacking off, and this is how you get away from the charge nurse, and then you're going to learn that in a hurry too. So I think as individual facilities, we're looking for that critical mass.
You said facility, Perry.
I know.
As individual organizations, what you're really saying is it gets down to the culture.
That's right.
Each individual organization and how we as an organization welcomes our staff, how our leadership prioritizes this kind of learning and working together and building teams where we're communicating these things and we're onboarding new people who are coming in. We're welcoming them and helping them learn what they need to be successful. And that's something that we've been working on for the past 5 years with our grants, is to try and help the nursing centers learn about building this kind of culture and realizing that it's not just about quality of care, it's about quality of life. And quality of life is just huge.
Right. And it's your onboarding, and we need to make sure that we are teaching culture awareness to a new employee, and not just throw them on the floor, but, you know, ease them onto the floor. And then when they do make mistakes, you lovingly tell them, you know, hey, this is how we do it. And that goes all the way to the physician and the nurse practitioner. The attitude of those people are very important. And that's my job, is to teach them to do that. Now, almost every meeting, we have something to do with the cultural resident experience and all that stuff, and the drugs. I mean, we've got one coming in January. First one we set up is deprescribing and optimizing drug therapy. So that we're kind of making a little scientific thing out of it. It's not just taking away drugs, but how are we optimizing drug therapy? And of course, we're looking at psychoactive drugs first. But the doctors are frustrated when they're told they need to reduce the dose, and they don't see what the staff is going to do to counteract that dose reduction, to make sure that dose reduction works. You don't just jerk the drug away and then see what happens. You once everybody should know Miss So-and-so just had her Zyprexa cut in half. So let's keep an eye on her. Let's see what happens. Let's see how we can react to that. But again, that comes with having a critical mass of caregivers that know that stuff. And so it's so important for the shift change to communicate those things. It's just a world of difference between first, second, and third shifts. I mean, this is just a total different experience for them. And if they're at least eased into saying, well, this is what we did, these are the things you need to watch for and help for, and then that really goes at 11 o'clock to the evening shift, because these people are trying to get out and all that stuff. So first thing you do is you teach them to show up to work on time, because if the person's having to hang around 30 minutes more, than they need to because you hadn't shown up yet, they're not going to be real happy about sticking around and telling you what's really going in the home. So, you know, culture change is a wonderful thing. GHCA is teaching a thing called Heart Forward. And
Right.
I looked into that, and it does mold just beautifully in with everything we're talking about. Hand-to-hand
Right.
molds in that. I kind of think of culture change as the PhD level, and the Heart Forward is kind of the Bachelor of Science level.
Okay.
But they all work together because we're all looking at the patient, I know, experience.
Right.
I'm going from a medical standpoint, from a person. Every time I go to the doctor, I get a dang survey within 10 minutes.
Right.
So, you know, and they think that's quality assurance.
Oh my gosh.
So anyway, that's all. The basic thing I had to say was our doctors really want to do this.
Right.
But I put the onus on them. Okay, then how are you going to translate that to a CNA who looks at you as God sometimes, and they shouldn't, that's for sure. But you know, if you go in the building and you're making rounds and you're talking well-being, and you know, she just seems depressed. And the first thing you do is you call the CNA into the room and say, or maybe just outside the room and say, what do you think about this? You know, what's the change? What's going on? Not only did you really get some good information with the CNA, you just bought yourself another year of employment for that nursing home, for that CNA, because they go back and tell their husband, oh my gosh, Dr. Warnock asked my opinion on this patient and we're going to improve her well-being. That'll keep a CNA there.
Well, and Perry, we've talked before about how really the doctors haven't had an opportunity to learn about person-centered practices and all of this culture change stuff, because that just hasn't been addressed to them. And
well, their geriatric care is a subspecialty. I mean,
Right.
unless they
Right.
got a fellowship and a geriatric board certification, which very few do, it's just kind of part of family practice. It's just, you know, that kind of thing, and they don't get very specific training, and that's what we do with AMDA and GMDA. I'm
Right.
gonna let you guys in on a little secret, and I don't want you to blab it everywhere yet, okay?
Okay.
GMDA voted overwhelmingly to say, you know what? Every medical director who is in a nursing home in Georgia needs to have direct training on how to be a medical director, not how to be a physician, but how to be a medical director. What are the management things that you need to be participating in, starting with QAPI? What do you know about nursing home operations? What do you know about working with families? And what do you know about the regulations? Well, a surveyor is going to call you and ask you questions, and if you blow off that surveyor, you just did major damage to your nursing home. And they're paying you extra on a contract to be a medical director. So the state of California has done it, and so has the state of Maryland. But we just petitioned the Department of Community Health to require every medical director to obtain the certified medical director status within 5 years of becoming a medical director.
That's
Because you have to be there 3 years as part of the stuff. And
That's awesome.
and it's half clinical, it's half management. Many of our doctors have been there 3 years, and they can finish this course very quickly and become a CMD. And that tells us, and the surveyors have already know this, if they see CMD next to the medical director, MD, then they know, okay, I'm home free. This guy knows, or this lady knows what she's talking about.
Awesome.
And So we figured out a way to get around the legislature. The state of Georgia, I don't know if you're aware that the survey agency is contracted by the feds to survey to the federal standards, but their first job is to survey to the state laws. And we have a Georgia state law and regulations for nursing homes. And we can amend the regulations for nursing homes without going to the state and all that. And we know CMS is not going to oppose it. So that's why we're asking the Department of Community Health Board to just go ahead and change the regulation.
That is excellent. And that's a whole other way that Georgia's leading the pack in some of our things that we have.
In that curriculum is the person-centered care, big time. So that's going to help a whole bunch.
And in the regs, as I pointed out earlier, it focuses on quality of life, not just quality of care. The regs focus on well-being, on preferences.
That's what we try to teach.
Right.
Yeah.
So great.
We're going to get there. I'm excited as heck about this because we're really adding numbers to people that even if they can't make a whopping change in their nursing home and getting resistance, they still know what's right. They know what's the right thing to do, and they can model that within the parameters of where they work. And then you work on the administrator and the DON who has a bad attitude. You figure out how to change that attitude.
And that's what we've been trying to do here. The way we've been doing the certified associate training and the Dementia Beyond Drugs training is we are really urging people to come together as a team and go through the class as a team, including the medical director, the nurse practitioners, the DON, the administrator, because then everybody's on the same team and on the same page. And that's what makes all the difference. If everybody knows that this is the goal and what we're going for and focusing on.
But then you have to take the next step because that team is your day shift. Let's face it. I would say that there's not a night nurse on this call right now because they're home asleep. But there's got to be an intentional way of saying, how do we stick around for the second shift and spend some extra time when we normally go home at 3 and help them through it. And then we'll push to the night shift and do the same thing.
Excellent point, Perry. Thank you so much for sharing that. And Danyce, what you two are talking about all fits in together. And now, let's have Jennifer Kraft Morgan, who is the director of the Gerontology Institute at Georgia State University. She's going to share some really great stuff with us.
If you allow me to screen share.
Yes, ma'am.
Please.
There you go.
So anyone who has been listening to this conversation will not be surprised by these results. But we have the results from the last class, not this class yet. I'm really excited about looking at the results for this class, but the data are not fully tabulated yet. So I can't. But we can talk a little bit about the last class and what we've been able to accomplish. So what we did for Dementia Beyond Drugs and CEAT is ask participants to fill out a survey pre and post about using the KCCI tool, which is the Kansas City Culture Change Instrument. And it breaks down into several scales that you see before you. So resident care, nursing home environment, relationships, staff empowerment, nursing home management, shared values, and quality improvement. And this is a sample item. So you can see how many items each of the scales have. And so you can see that resident care sample item is residents choose when they eat each meal. There's items on sleeping and nursing home environment. This nursing home looks and feels like home. Relationships, families know who takes care of their loved ones. Staff empowerment, staff teams create their own work schedules. Nursing home management, nursing home managers try to improve working conditions. Shared values, how much you agree across staff in terms of home-like environment, respect for coworkers, quality of life for residents, and then quality improvement. This nursing home evaluates our care and services to make improvements. So we looked at each of these scales over time from pre to post to see in those short 6 weeks for the first class and 7 weeks for the second class, in those short 6 weeks, did we move anything? Do we move the needle on any culture change measures? And unsurprisingly, we did. So this is the overall thing. We looked at 97 cases that we got data from, staff from 22 nursing homes. As Kim talked about, we've chosen for our CEAT classes and our Dementia Beyond Drugs classes to try to develop teams within nursing centers so that they're able to work together and start moving some of these processes forward. And so we see a significant improvement in nursing home environment, remembering from before that that's nursing home looks and feels like home is one of the item measures. And in relationships, again, one of those big building blocks of culture change and of getting to know people. Families know who takes care of their loved ones and, all the other items. And then we also saw in an added measure that looked at antipsychotic practices around antipsychotics, we saw the increased attention to the use of antipsychotics in staff meetings. So more people were talking about it and trying to figure it out and trying to think about it with their interdisciplinary care teams, which is very exciting. So that this little class on this small number of participants, 97 isn't small in how much impact it has, but it's small in terms of power, statistical power. It's pretty impressive that the class changed these 3 metrics and improved person-centered dementia care practices overall. So that's the other one was the use of antipsychotics. Is the alternatives to antipsychotic drugs are discussed and promoted in staff meetings. So that happened more often post than it did pre.
Okay.
So people started talking about it over the course of the class. So that's all I've got. It's pretty simple, but it's powerful, right?
It is powerful. And we know, as we've talked about a lot of times people don't know what they don't know, and they haven't had an opportunity to be exposed to this kind of education. And the Maya quote, "We did then what we knew how to do, but when we know better, we do better." Really, it's true here. And bringing people together and having shared learning and creating a learning organization really makes a huge difference. And focusing on not just quality of care, but quality of life and well-being, and really making sure that people know and understand dementia. And unfortunately, there's not excellent education about dementia has infused the world. As Danyce was saying, the hand-in-hand training kit, it's a big fat kit, it was introduced and given to every nursing home in the country, but it was BC, before COVID. So a lot of people have kind of, it's off their radar. So not everybody is going to be able to take the Dementia Beyond Drugs class, but hand in hand is something that's free that everybody can use and figure out how to integrate. And Leanna, with you work in an affordable housing community, for example, and there are people living with cognitive challenges in that kind of an organization, just like everywhere. So the importance of some dementia education for all of the staff in affordable housing. Can you talk about that for a minute?
I would love to, because something happened just last week. I cried about it for like several days. I'm still not okay, but anyway, I may start crying now. But anyway, so I was on the elevator and there's this woman who her daughter is her caregiver, and she kind of comes and goes. She mostly lives in her apartment. So anyway, she was on the first floor, and she's using a walker. Her slippers aren't on her feet correctly. She's going to fall. She's very disoriented. She said, "Hey, where's the 14th floor?" Which is actually where she lives. So so I was like, "Hey, you know what? I'm going there. Let's go together." And so I get her back on, and she can't remember her number, the apartment number. So I, kind of slowly walk with her. We figure it out where her apartment is. The door's not locked. It's not even closed. So I push it open and she will not go in. And I was like, "Miss Juanita, this is your apartment, right?" And she said, I think so. I don't know. She wasn't sure. So I said, "Well, is it okay if I go check it out? See what's in here?" So in this apartment, there are no photographs of family. There's no way to orient to, it was stunning. And so her daughter, I'm sure, I have no idea what's happening, but a bunch of stuff is in suitcases. There's a bunch of other stuff that's in boxes. So this woman has no home. She's sitting in the hallway homeless in her home. So anyway, so I called up the supportive services coordinator and said, okay, invite him in. He knows her. So, she was cool. We weren't, like intruding. We had to give her a chair because she's not going in. She will not go in. And so I showed him around, and I was like, I asked him, "What do you see? What are some things that stand out to you in here?" And nothing really did. He didn't realize there's no photographs of her. She has 10 children, which
There's
how many
nothing
grandchildren?
that says home.
Home. This is my home. These are my things. This is where I am safe. This is, this is a place I know, right?
This is where I belong.
Oh my gosh. And so maybe her daughter, for expediency, right? I don't know. Maybe she's thinking, it's imminent. We're going to have to move. I don't know. But most of her things, just the presence of all the packed boxes. No. And also that's in the living room. And then in the bedroom, there's several suitcases that are out. So everything about this place says transient, not permanent, not mine. Not whose is this? There's nothing to identify it as hers. And so, but it was so good to walk him through that. When I mentioned it, of course he was, but we're not looking for that necessarily. And so anyway, it's a thing. These things are happening in this place. And also, if I may also say, because I told you guys, like, I have a daughter who's deaf. She has cerebral palsy, developmental disabilities. So just like, you know, I don't want to minimize, I hope this doesn't minimize dementia in any way,
No,
but there is her perception of this environment is different than mine. Like, time has no meaning to her in any way. And so for me to like, I'm expecting her to understand things. This Dementia Beyond Drugs has been so good for me, but just in, you know, my personal life, especially, but so I think I'm communicating a thing to her, which I am, but she can't receive it. And
Yeah.
so because she has no real concept of time now, and I think this is new, right? You know, she's 38. We've done this for a while. We've done it. I mean, we thought we were doing a good job. We thought we knew what we were doing, but she's in a new place now.
Right.
And so we all have to just adjust. And that's one of the things I did tell Kevin was that, you know what, at one point, some people are here. This beautiful woman with dementia. Perhaps this was okay for a while, but the indication we must pay attention to is that it's no longer okay.
Right.
Right.
That's,
Yeah.
thank you for sharing. So yes, and yes, this kind of education is important for everybody at all levels in all places. And it's not just for old people with dementia. It's for anybody that has any kind of cognitive changes, challenges, and anything that we learn for dementia and cognitive challenges is good for everybody. You know, we're learning how to improve quality of life for everybody, no matter where they call home. And that's so important. And I have some resources that I want to share with you guys really fast, just to remind us of all the resources that we have, that you all can use, that we have available. So let me share this screen. Just quick reminders. We know that not all dementia education is created equally. Just because people say it's dementia education does not mean it's person-centered dementia education. In Georgia, we have a dementia plan, a state plan. It's called GARD, the Georgia Alzheimer's and Related Dementia State Plan. And we actually created a competency guide for dementia care to help people, organizations learn how to shop for good dementia care that is focused on the right things. So that can be helpful when people are trying to compare different trainings, different approaches. And I hate the word training because you train a dog, but different ways of being educated, different approaches. And we've already said it, Perry spoke really nicely about this. Training without support from leadership and the management, you know, from the high ups, corporate, you know, we have to have support at that level to make all of this be able to happen. And it's important as well that the leadership and management also go through the education so that they know what everybody else is learning, and so that they can model it and talk the talk and walk the walk. It's really important in developing a culture within an organization. So just in terms of resources, this is just an aside, but there is an opportunity. There's a pilot that I'm involved with that is doing an assessment on the environment in nursing homes and assisted livings to use and try out. It's testing an assessment tool to, really look at an environment to see, is it a good environment for people living with dementia? And we're looking for 20 to 25 environments, organizations close to Atlanta that are interested in this. It's not anything, you're not going to get in trouble if you don't have everything in place. At the end of it, you get a free report that gives you an analysis of what we find. So if anybody is interested in participating in that, holler at me. And then I'm just reminding us about our website and to sign up for the newsletter so you can make sure that you get updates from us. And you get on the list. We don't bombard you, but it helps you keep in touch with everything that's going on. And we have many, many, many little short 2 to 5 minute videos, I think over 50 now, on YouTube. It's easiest to find them on YouTube and go to the Culture Change Network of Georgia channel. And you can look under playlists. We have them divided by topic, kind of by theme. And just if you go to videos, you can see all of them and that are really helpful. And in terms of dementia, we have all of these and all of these that are just focused on dementia. So even using those are a great way to start some education in your organizations. Just starting with that, it's easy to find them. They're short, they're free, and it can, really help get the conversation going. And I'm reminding us, just so I don't forget, I'm channeling my friend Sharon Hall. Not all people with dementia are old. We all have to make sure we keep remembering young people that are young that have dementia and not forget about that. We also have webinars. And even though they happened in the past, we've recorded them and you have access to them on our education channel, our education website. And we've got links for those. So you can access those, and that they have handouts and really good information. We did several of them with Dr. Cameron Kemp, and we did one with Candace Kemp. So some really, really great information is available, and we have a handout. We can email or link. I'll link in a minute this new handout that includes all of this, as well as some information on we're adding QAPI and QIO quality improvement webinars and videos. So you need to be watching out for those, because they're really helpful short videos that help teach about SMART goals and, the approaches to doing quality improvement. And we've got webinars with Alliant that are really helpful. We have one more year of our grant. And as a part of that, we'll be offering the Certified Eden Associate training again for one more year. And that is basically the what, why, and how of person-centered care. It's the heart and soul of person-centered care planning. And as of now, our estimated dates, or that class will start in February. So that's another reason to sign up for the newsletter, so you can keep up with all of that. And we'll be offering Dementia Beyond Drugs again in the fall. So also, don't forget about the Eden Alternative website and their information. You can look into becoming an individual member or an organizational member to stay really connected to what they're doing as well. and we have a webinar coming up next week. So it's free. All this stuff is free. So be on the lookout for that. It's about building effective relationships using trauma-informed approaches. And that'll be with Dr. Jennifer Kraft Morgan and Dr. Lynn Royster. And it's part of our trauma-informed approach series for staff to really help us help staff. And then, of course, stay connected to us on social media. And I'm stopping sharing now. And I just want to say, does anybody have any questions or comments? Anything anybody want to say before we sign off? Danyce, thank you so much. And Perry, thank you for joining us and helping have this conversation. Really appreciate everybody being here today, and look forward to staying in touch with everybody. Jen, anything else you can think of?
No, ma'am. Thank you all for caring enough to show up. We appreciate you.
Absolutely. Thank you.